Good morning. I'm Tim Kern. I'm going to give you I would say, a preclinical or translational approach to diabetic retinopathy. This is an area that we've been working in for quite a while. And basically what we are suggesting is that the retina may not be the initial problem with diabetic retinopathy. Basically what we have evidence is that it's actually caused by the white blood cells, and this has implications also for treatment of other complications, in particular the kidney and the nerve. So right now, clinically, diabetic retinopathy is diagnosed based on its vascular abnormalities. So obviously we have dot and blot hemorrhages, we've got cotton wool spots, hard exits, and a lot of capillary obliteration here, patches of neovascularization. If you remove all the neural retina in a microscopic, to make a flat mount basically, the vasculature is profoundly affected, and that's been recognized for a long time. So here's some saccular microaneurysms, here's some obliterated attempts at new blood vessel formation which remain within the retina. And then there are large areas over here of total capillary obliteration. And basically, you can tell that histologically there are supposed to be nuclei all through the vasculature, and over here there's absolutely nothing, and if you do a clinical pathologic correlation, there is no flow through these vessels. So this is a histologic equivalent of a non-perfused retina over in this particular region. So this has basically been the standard line in terms of our understanding of diabetic retinopathy. Elevation in blood sugar cause a variety of metabolic abnormalities that lead initially to the non-proliferative stage of diabetic retinopathy, and capillary degeneration has been the hallmark of this because the clinical impression is that it's the capillary non-perfusion. These dead capillaries start off as individual, but then they begin to coalesce together into larger and larger areas of non-perfusion, leading to retinal ischemia, and then get release of vasoproliferative factors like VEGF and the eventual neovascular response. What I'm going to try and present some evidence is that the umbrella term that defines what those metabolic abnormalities that are resulting from hyperglycemia are inflammatory in nature. And as a result, there is a lot of therapeutic implications to this. The evidence right now that is known clinically is that anti-VEGF therapies are very potent in terms of inhibiting at least the advanced stages of the retinopathy, and corticosteroids, which are probably the strongest anti-inflammatory agent known right now, are very effective at retinal edema, neovascularization, and even the earlier stages of the retinopathy. So in terms of the animal studies, we're focusing on the histologic picture, and in particular what we're trying to do is count these degenerate capillaries, because these are what we believe progress to ultimately lead to the neovascular response. This is the postulated inflammatory cascade that leads to retinopathy. We have studied every single one of these steps, and all of them are sequelae of diabetes, and all of them, if you block them, can stop the capillary degeneration. It's really not important to pay attention to each of these, but the reason that we've done this is because this allows us to identify probably the safest and most effective places to try and intervene therapeutically in patients. So just as an introduction here, I mean, this cascade here has a bunch of arrows going in one direction. And there is a reason for that. For example, if we give an inducible nitric oxide synthase inhibitor or knock it out genetically in animals. There are some things that are changed in terms of other metabolites. And so just for example, we found if you block this, you're also blocking the upregulation of these proteins. But you're not blocking this. And so we did this over and over and over again, and eventually we were able to put things into a linear cascade. So all I want to basically point out is that we've been able to inhibit the diabetes-induced degeneration of retinal capillaries by a whole variety of pharmacologic and genetic modifications that have given us a strong impression that this is an inflammatory cascade that's going on. And so, as I mentioned before, this concept that inflammatory processes are important in diabetic retinopathy is consistent with clinical evidence with regard to VEGF antagonists and the intravitreal injection of steroids. There are therapeutic implications of this information. First off, there are much more potent anti-inflammatory agents now and much more selective that can be used to try and inhibit the retinopathy. And we're talking about the early, the non-proliferative stages of the retinopathy. There's a variety of studies going on right now in small early patient trials using different salicylates. Tom Gardner in Michigan has a trial going on right now with doxycycline, which is a tetracycline derivative, which we and others have shown have very potent effects, at least in preclinical studies. The other thing that's interesting, though, is several drug companies now have some non-corticosteroid mimetics that activate the glucocorticoid receptor but don't have any of the bad effects. They don't have bad effects on IOP. They don't cause cataract. And so these are new therapeutics that are being developed with the intent of trying to have mimics the good effects of steroids without the bad effects. The issue of inflammation, though, is basically comes down to where is this happening? There is some evidence that there are inflammatory changes occurring within the retina itself, but what I want to present is data that indicates that the retinopathy is initiated in the white blood cells that are flowing flowing through the retinal blood vessels. And so basically, just as a review, as in any inflammatory cascade, white blood cell adherence to the vasculature is a very uniform characteristic. And so there are, the white blood cells have a variety of adhesion molecules that slow them down, initiate rolling across the endothelial surface, and then eventually the white blood cells stop with things like ICAM and other integrins, so that it's a permanent occlusion. These, in diabetic retinopathy or in diabetes, within the capillaries of the mesentery, of the cheek, and of the retina in particular, there is evidence that these occlusions last for an hour or even up to a day, but they are not permanent. So one basically interpretation of diabetic retinopathy that it's a repeated series of subclinical infarcts and vaso-occlusive events that are going on, and it's only after you've done this over and over and over again that you begin to see morphologic manifestations. So to test this in animals, at least initially, we made chimeric animals. Basically what that means, just like from the old the Greek legends, it's part of one animal and mixed together with another animal. So what we did is we took regular mice, non-diabetic or diabetic, and we irradiate the animals, kill all their bone marrow. Then take the bone marrow from a genetically different animal that lacks an inflammatory protein and put them together, and so you have a chimeric mouse. For example, with this example using the inducible isoform of nitric oxide synthase, which is a characteristic inflammatory protein. You have the white blood cells, only the bone marrow-derived cells lack this protein. The rest of the body has it. Or the opposite way is that only the white blood cells have this protein, and the rest of the animal doesn't have it. And just as an example, here are three of these proteins that we've done this to. And basically, I just want to show you. So here are normal and diabetic animals. So diabetic animals get an increase in this capillary degeneration, which we have quantitated. After this irradiation process, basically the same thing happens. There's no real difference because we're putting back in normal white blood cells. So the irradiation process doesn't do anything bad. But if you put in white blood cells that lack this inflammatory protein, the capillary degeneration is very significantly inhibited. If you do the opposite, the whole animal lacks INOS, but only the white blood cells have it, the retinopathy is back. That pretty strongly indicates that it is the white blood cells that are initiating this pathologic response to kill the retinal capillaries. This is just another example using a different inflammatory protein. Again, this capillary degeneration is very significantly inhibited. White blood cell adhesion to the blood vessel is classic marker of inflammation. These are the two controls here, and basically this inflammatory response is totally missing if we take out the inflammatory proteins only from the white blood cell. Same thing here, just another example. This is oxidative stress by the retina. If you remove these inflammatory proteins out of the white blood cells only, diabetes no longer causes an oxidative stress. The oxidative stress is probably one of the strongest predictors of diabetic retinopathy that we have from a preclinical standpoint. And basically, there's substantial evidence that indicates that it is the oxidative stress that initiates the inflammatory response within these tissues. So basically, the bone marrow cells, and specifically inflammatory proteins within those marrow-derived cells, play a critical role in the development of the retinopathy. So the question would be, which one of these bone marrow-derived white blood cells, just going back to basic hematopoiesis, the cells are all derived from a stem cell, and then in the presence of a monocyte colony-stimulating factor or granulite colony-stimulating factor, they go in different pathways. And so we made some chimeras, again, using this knockout, which had a profound effect on neutrophils. And basically, these chimeras work very effectively. They went from about 20% of in a normal animal down to a little more than 1% in these chimeric animals. So we basically made a neutrophil knockout. And in those animals, the retinopathy was totally prevented. So the indications are that neutrophils specifically are playing a critical role in the initiation of diabetic retinopathy. We've done these kinds of chimeras with lots of other proteins, all related to inflammation or oxidative stress, and again are having very profound effects on the retina. The retina looks like it may be responding to a trauma caused by the white blood cell. Whether it's a physical trauma or a chemical trauma, we don't really know right now. The thing of it is, though, is this has therapeutic implications because you don't have to give anti-inflammatory therapies just to the eye. There's, like I said before, there's accumulating evidence that this inflammatory response is having a critical role in the development of at least diabetic kidney disease and certainly the neuropathy that happens in the peripheral neuropathy. But there are therapies that are being tested right now that block the interaction of activated white blood cells with the endothelium. And so one in particular is called Neutrophil Inhibitory factor. This was developed by Lilly and has been in a couple large cardiovascular clinical trials, but now it's being turned over toward retinopathy. So this is basically, as I mentioned, the classical understanding of the pathogenesis of diabetic retinopathy, but it really ignores the second half of the disease. Obviously, these the lesions in background retinopathy have strong predictive power into who is going to lose vision. Microaneurysms have been used for a long time to predict the likelihood of progression to visual impairment. But there is a neuropathy itself that happens within the retina in diabetes. And it's, there are lots of electrophysiologic, color sensation defects, contrast sensitivity, visual acuity, a lot of these different, I would say, neural defects that are clearly related to the vision loss that patients can suffer. So it remains to be determined, what do we call diabetic retinopathy? Is it based on the vasculature? Is it based on visual function? Because right now, that's a question that is coming up a lot more. I just want to show you two therapies here that we have done before that stop the capillary degeneration. And here's the data. Here's non-diabetic animals. Diabetic animals have an increase in the capillary degeneration, and this was significantly inhibited by this P38 inhibitor. This was a 9-month study in animals. Same thing over here for a RAGE inhibitor, significantly inhibited over a period of 10 months in this particular preclinical trial. But what happens to vision? I'm just going to use contrast sensitivity as an example here. So here are non-diabetic mice. So we can actually measure contrast sensitivity and visual acuity in animals now. So here's the non-diabetic contrast sensitivity curve for mice, and here is diabetics after 8 months of diabetes. This is significantly different. So diabetes causes a significant reduction in visual acuity and contrast sensitivity. If we look at these same drugs, the P38 inhibitor, the RAGE inhibitor, there is no significant effect of either of these two therapies on contrast sensitivity. So basically what it says is that diabetes-induced defects in visual function likely arise by different pathways than cause the vascular abnormalities. These are different animals. Now, there are obviously a lot of things in clinical practice where you get preretinal membrane or preretinal hemorrhage, things like that can physically obstruct light from getting back, and vitrectomy or something like that can clean that up. And that obviously is a major cause of vision loss, but there is also diabetes-induced defects within the neural retina itself. This same kind of conclusions were obtained in over the last couple of years in the roboxastorin trial for a protein kinase C inhibition, and basically what they found was that this therapy had significant effects on the visual acuity, but had no beneficial effects on neovascularization or other morphologic descriptors of diabetic retinopathy that we've been using clinically for a long time. So basically, the inflammatory processes that damage the retinal vasculature in the early stages of diabetic retinopathy are at least initiated by white blood cells. There is clinical evidence indicating that the neovascular response that occurs in different diseases, in particular AMD, is also got a strong inflammatory component, and looks like there is some evidence that this might be inhibited by anti-inflammatory approaches. The other thing that's worth, basically pointing out is that these diabetes-induced defects in contrast sensitivity, visual acuity, and perhaps other neurologic parameters that bring patients into the doctor's office sometimes actually seem to arrive by different molecular pathways in diabetes than do the vascular abnormalities themselves. I just want to recognize lots of people who have helped me do these studies over the years. Thanks.